school EMDR, we would sit about this close. But in most traditional psychotherapy, we are quite a distance away. And so this creates an opportunity and also a couple of variables that we need to keep in mind because it also creates some risks. So this chair setup is called chips passing in the night. The idea being that if any point in time Lynn feels uncomfortable, she can get up and move. I am not blocking her in any way. That is extremely important as we are doing some pretty intense work. And it's very important for her not to feel trapped, stuck, paralyzed. We'll be talking a lot about the idea of inescapability and how that's fundamental to a trauma encoding. And so if we create an environment of being trapped while doing the trauma work, see why that'd be less than preferable. Now I know Lynn, so she said I could play with her a little bit for your guys. Say we're sitting here doing this work and I'm like, hey, how's it going, right? Or imagine, hi. Now we know each other, right? But as a client-practitioner relationship, what are you noticing? Yeah, she's wrapped. You want to wear my, I know, I have, yeah, my hands are cold. Yeah, she's trapped. If she opens her eyes at any point in reprocessing, which frequently clients will do, and say we're working on a perpetrator, what's the first stimulus she's going to see? Me. I become the stimulus representation of the perpetrator. Now, if it's a male and a female, what else do you notice? Right? Pretty sexualized. Yeah. So we need to be very mindful about space and distance. So whenever I begin to set up for the facilitated havening process, my chair is on wheels. And so I start my chair here, and then I sit and go, is this distance comfortable for you? Would it be okay if I brought my chair closer? Every step of the facilitated havening setup process, at least at the outset, is about invitation. Once you become comfortable working with them, the invitation can be a little less focused. But it's always about being invited into their space. We never want to be presumptive. It's all about being client-centered. Their safety and security is first. Now, may I sit with my chair this close? Yes. Is this comfortable for you? Okay, thank you. Now, there's 3 types of touch, and I never presume that they're on board with me doing all 3. I have had patients who are just okay with hands at the outset. I have some patients, interestingly, who are okay with face, but not shoulders or hands. Well, and that would make sense if they're sexual assault survivors. Maybe okay up here, but this could mime the assault. So again, I always ask permission. May I bow your hands? Okay. Just rest them comfortably. And again, my hands are cold. First touch is just like this. Is this comfortable for you? And is it okay if I touch your shoulders? The second touch starts at the top of your shoulders and comes down just like that. Is that comfortable? And this touch will frequently come all the way down to your hands. Is that comfortable? Now you'll notice my hand. Thumb is where? Up. Right? Bow your shoulder again. Now, if my hand is like that, what do we run the risk of? Boob graze. Yes. And again, I work with a lot of sexual assault survivors. If I come at her like this, right? And even just as a woman myself, if somebody comes at me like this, what are you doing? Right? So it's a gentle around, thumbs up, palms. Okay? And that we will be walking around as we are practicing today, and we will be adjusting your hands because it is normal to go like that. And let those thumbs open up. We do not want those thumbs opening up because then, yes, we can get some breast involvement, which we certainly do not want. So thumbs up. And that is something that initially is not going to be a natural muscle movement. So if we come and adjust your hand, just know we're helping you out and you will be thinking about that quite a bit. That's okay. It will become natural. Now, I'm going to ask permission to approach your face, so may I haven your face? So the first touch is right up above the brow. Just like that. Is that comfortable? And now we're going to come down to cheeks. How's that feel for you? I'm about to haven somebody's face, I'm going to walk you through exactly what I say. I'm going to show you what the face touch feels like right now. And you'll notice that as I approach your face, I'll say the word face. Face. And the reason I do this is to let your subconscious know that a touch is coming. We are not used to people walking up to us and randomly having our faces. And so I'm just letting it know. And so every time I approach your face, I will say that word. You don't need to do anything. It's just a gentle acknowledgement that, oh, this is happening. How does this feel for you?
Really nice.
So you're a clinician as well. Any feedback on walking through this?
Very nice and gentle and soothing all day.
Yeah, and that is the goal, is to be very gentle. As Dr. Stephen Rudin says, it's gentle but with authority. Okay, so we are the guides, and often I'll have clinicians who will ask me, well, do we check in and go, I can borrow your shoulders again. Does that need to be faster for you, or slower, or harder, or more gentle? And what we're doing is showing them in some way that they need to control the session, which once we get associative processes going, which we'll talk about with the serotonin, we don't want them controlling the session because their brain will just go. And so it's all about being gentle but with authority. Okay. Thank you very much.
Thank you.
Thank you for recording that.